All right, good morning, everyone. I'm Landon Mueller. I'm an EM doc and sports medicine doc at Georgetown and MedStar Health. And I'm really excited to be delivering kind of my annual update on the top 5 MSK articles that have been published in the literature. This time it's the 2021 update, and I'll explain why that is. I don't have any financial disclosures. So let's go back in time to 2021. It was a weird time. We were like maybe getting out of COVID. We had some positivity, vaccines were rolling out, and then kind of the Delta variant hit during the summer, and that kind of took away some of our plans and a lot of other stuff. But 2021 was an interesting year. And why am I talking about 2021 when we're in 2023? Well, this is how it works because I have to review all the articles from 2021 in the spring of 2022, and then I submit that proposal for this talk in the fall of 2022, and now it gets to SAEM 2023. So that's why we're always kind of 2 years behind the actual calendar year when we're discussing these articles. And basically what I do is I sit down and I torture myself for a couple of days where I go through all of the possible journals that I can find through all their issues from that year and try to pick out the articles that I think are really relevant and practice changing or just interesting to talk about. So there is a lot of my own kind of personal bias and subjective bias, but hopefully I try to bring 4 or 5 interesting topics that we can talk about. So I go through all the different emergency medicine journals, orthopedics, sports medicine, some big name journals like New England Journal of Medicine, JAMA. Then I go through radiology, look through that. Then I look at things that could potentially be MSK sports medicine, and then I go through a couple journal aggregators. And I come out with all the articles that we're going to talk about. So, all right, let's get going. So case number 1, our first kind of big series is how do we treat low back pain? This is one of our least favorite complaints in the emergency department. I know that as an ER doc, and then I still have to see these patients in clinic as well. So it's something that I have to deal with quite frequently. And it's something that's frustrating to a lot of us, especially in the emergency department with acute low back pain. And we've actually got a series of articles, including this article looking at NSAIDs for acute low back pain, a randomized controlled trial looking at a couple different NSAIDs, the effectiveness of intradermal sterile water, we'll talk about that, and then the clinical course of patients with low back pain. So first of all, what do we know about low back pain? As I said, it's difficult, it's frustrating to treat in the emergency department, and it's a major source of pain for both us and our patients. Get it? Okay. All right. So the first question, this article, this was a systematic review of NSAIDs looking at their effectiveness for low back pain. And there's big, busy table. Ultimately, the one thing I want you to take away is the NNT to treat low back pain intensity was 1 in 14. So an NNT of 1 in 14 to treat NSAIDs, and I will tell you that the effect size was pretty low, a 7.3% reduction in pain intensity within 3 weeks, which is not very good, I would argue. It's better than a lot of medications that we use for NNTs, but if our goal is to help with pain, it's a pretty small effect size for a decent size NNT. So then I asked the question, maybe there's some difference between NSAIDs and their actual efficacy. Again, busy slide. What I will tell you is ultimately there was no statistical difference between ibuprofen, Toradol, and diclofenac pills. They all essentially had the same efficacy or relative lack thereof. So then I look at maybe there's some difference in adverse effects. And this is where we start to maybe see some difference, primarily with ibuprofen having more kind of GI side effects than other oral NSAIDs. And we've kind of seen that in some prior studies in the past. And so for that reason, that's like one key takeaway for me is that ibuprofen works great. It's over the counter, it's cheap, but it does tend to have more stomach side effects. And I'll explain that to patients and then offer a prescription form, whether that's diclofenac or meloxicam are some of my preferred NSAIDs. So moving on, NSAIDs don't work, or they work, but it's pretty small effect size. Maybe we can do something else, like injecting sterile saline into the back. This was a very interesting study published out of a single site in Turkey, where they basically took sterile saline and injected it just in the dermis of the back. They did it in like this 4-quadrant pattern in the back and then measured pain response. And surprisingly, the patients that were randomized to the intervention versus just other oral medication had reduced pain scores. Now, this is kind of a head-scratching thing, like how is putting intradermal saline in the epidermis actually making any difference in back pain? And I don't know, the authors don't know, what I would say is that pain is extremely complex. Some of the thought process is one, obviously placebo effect. You're having hands-on manipulation, you're doing something to the patient. I think there is some benefit of that. There's also this idea that by doing something to the actual area, you're basically inhibiting the pain response, or you're telling the pain response from the nociceptive nerve fibers that they're okay, and then they stop sending that pain. It's pretty complex, head scratching, but I've never actually done this. I do something different, which is trigger point injections, although the idea is that you're putting the needle into the muscle to try and inhibit that pain response, but I think ultimately it may end up being a very similar pathophysiology of why that works and why intradermal saline works. This next study looked at kind of the clinical course of low back pain in patients, and my big takeaway is this graph here, which is pain intensity over time and days. So they followed some of these patients out 3-4 months from their initial pain visit in the emergency department. And the big takeaway is obviously patients are in a lot of pain with very high pain scores initially on presentation. And then over time, they all seem to decrease. Like, that's kind of what I tell patients, and there are some other studies that have looked at this, that in general, patients seem to get better in about a month. Kind of no matter what we do, they're ultimately going to get better. Sometimes it doesn't completely go away, but most of the time with patients with acute low back pain that's kind of mechanical in nature, non-radicular, they are going to get better, whether that's pain or disability, which is the second part of the graph. So my takeaways from those 4 articles: the NNT for NSAIDs and low back pain is 14. The effect size is fairly small, but we're all still going to use it because it's something that we can give patients and they're cheap. There's no major difference between NSAIDs for efficacy. Ibuprofen may cause the most side effects. We don't really understand pain. Never underestimate the placebo effect or just laying hands on the patient. And I generally counsel patients that they will feel better, probably regardless of what we do for them. Moving on to our second clinical question of the day is, how do we treat rib fracture pain? And pretty much every year I try to find some study looking at regional anesthesia. That's kind of a interest of mine. And so this one was analgesic efficacy of the serratus anterior plane block in rib fracture pain, a randomized controlled trial. And this was probably the first study that was published as a trial in the emergency medicine literature. We know rib fractures are extremely painful. We know that rib fracture pain control is very helpful in preventing complications, and that multimodal pain control is the name of the game now. The serratus anterior block is a really slick regional anesthesia block that really anyone can learn. It's ultrasound guided. You do 1 block on each side that essentially blocks 5 to 9 ribs as it spreads through the tissue plane. And you can do it with the patient lying supine or lateral decubitus. So I'm not going to go over the exact technique, but I'm just kind of introducing it for those of you who may not be familiar with it. The serratus anterior block, this is what it looks like under ultrasound. It's actually very superficial, very easy to identify the structures on most patients, even those with more adipose tissue. You basically find the corner of the latissimus dorsi muscle and the serratus anterior muscle, and you basically just deposit the anesthetic in that area. And it's a plane block, so it spreads out and covers the intercostal nerve muscles, basically in ribs 2 through 9 or so. So it's very easy to get multiple ribs for pain control. And the prior evidence has really just been some case series for rib fractures, herpes zoster pain, and even putting in pigtail chest tubes. There was one kind of retrospective study that did show decreased opioid usage after a serratus anterior block, but that wasn't necessarily a trial. And then we have plenty of anesthesia literature showing that it improves pain and inspiratory capacity. So this was also a single site in Turkey. They randomized patients to the serratus anterior block plus IV tramadol or IV tramadol alone. So not the greatest comparison. And the data is not super convincing in terms of their pain control was all about a level 5 out of 10 initially. And then the serratus anterior block did decrease down to 1 out of 10 compared to the control group getting IV tramadol, which went from 5 down to 3. So it was statistically significant. They did also show that there was decreased opioid consumption in those that had the serratus anterior block. We're going to go over a bonus study, though. So that prior study showed that, provided some evidence that this does work. And then this bonus study published in AEM Educational Training showed that we can teach residents how to do it. It was basically resident learners at a single center. They did some baseline testing, they did a didactic video, and then they did some practice on a model, and then basically proved afterwards that the residents felt more confident in the procedure, and then they did better on a checklist. So again, my takeaways, obviously I'm pretty biased towards regional anesthesia, but I think this is a pretty simple procedure that we can do for our trauma patients and our rib fracture pain patients that will certainly be a component of multimodal pain control, but it may help us reduce opioid consumption, may help reduce pain, and it can be taught to both ourselves and our learners. Moving on to our next clinical question of how do we treat concussion? And this is what I see a lot of in sports medicine. And this study was a small paper published looking at the efficacy of PO magnesium in the treatment of acute concussions in teenagers. Concussions account for 1 to 3 million ER visits a year. The mainstay of treatment is primarily rest and then graduated return to activity. We also know that physical activity has been shown to be helpful in recovery, and so that's something big that we are now advocating for not only our athletes, but patients in general to get some physical exercise. But what if there's something else that we can prescribe for them to help them with their symptoms? And this was looking at PO magnesium. Magnesium has been looked at in other forms of TBI, like moderate and severe TBI, and has shown some promise with those studies. So this was one of the first ones looking at concussion, especially in the emergency department. So single center, they were randomized to receive 500 milligrams PO magnesium oxide or not, and then they followed up the concussion symptom severity basically at 1 hour and then the next couple of days. This was a very small study, 17 patients total, and the statistics were like significantly-ish showed a decrease. Like if you look at this study, they note that the p-values between the treatment arms and everything were not statistically significant, but then they did some statistical wizardry and ultimately they concluded that magnesium did help out. Again, I don't think this is a very strong study to really support it, but again, we don't actually have much else to do for our concussion patients. And magnesium is cheap, it's over the counter, it has very low side effects. If anything, it will help them have a softer bowel movement in the morning. There's really very little downsides. And so I will prescribe magnesium to my patients in concussion clinic. We don't really know why it helps. Again, there were some studies that it may have some like neuroprotective factors. My thought process is it helps with sleep, and that's what I tell a lot of my patients. There is also another small study looking at just purely headache prevention in concussion, so it may help with that. We don't really know, but it's something that you could tell patients. It's easy, cheap, very little downside. And hopefully we'll get more studies in the future to confirm that it does do something. So moving on to our fourth case, which is, do I need an x-ray for nursemaid's elbow? We all know this is one of the most fun things to do in the emergency department is reduce a nursemaid's elbow, but no one's actually looked at the kind of frequency of x-rays and are we missing fractures in these children with nursemaid's elbow. So that's what this study did, published in the Annals of Emergency Medicine. So we know nursemaid's elbow, super common, super fun. It's primarily between the ages of 1 and 3. Classically does not need an x-ray, and as I said, there's been no published studies examining missed fractures in these patients. So they used a multi-center retrospective database to look for missed fractures, and the primary outcome they looked at was incidence of missed fracture during the initial visit. And I include this graph. I think it's very interesting. This was the number of visits by age distribution. So as we can see, primarily this occurs between ages 1, 2, and 3. And as we'll talk about, once you get into the age range 4, 5, 6, you need to consider that this might not be nursemaid's elbow. I have seen it in those age groups, but it's just less common. And so they noted that x-ray were actually performed at 28% of the visits, most often in the very young and the very old, because again, once we get out of that age group, we start to think, is there something else going on? They noted that the incidence of missed fracture was just 0.9%, and it was most commonly missed in the older age group, basically with an odds ratio of 2.3 in those age 6 or above, which I would argue like age 6 is very old to be having a nursemaid's. And the authors basically concluded, and I think it's what they actually concluded is great takeaway. For every 1,000 children with a diagnosis of a nursemaid's elbow, only 3 returned with an upper extremity fracture within 7 days. So I think that really highlights that when it is classically a nursemaid's elbow, in the right age group, you don't need an x-ray. Just reduce it, send them home. And they note that missed fractures were more likely in older children, those requiring analgesics in the ED, and those for whom their clinicians ordered radiographs on the initial visit. So my takeaway from that is basically, if you have an index of suspicion that it's not just a radial head subluxation, then you have to consider something else. And again, consider that in the older age group, but for the classic 2-year-old, nothing else to do, just reduce it, send it home. And then lastly, going over some innovations for MSK in the emergency department. These are just a few fun studies that I think can really change how we practice in the future, including looking at the use of AI for radiograph interpretation, and then also direct access PT in the emergency department. So starting off with the AI study, we know that extremity fractures are actually the second most missed diagnosis leading to a medical legal claim, and that missed fractures represent 80% of the diagnostic error in the emergency department. So it's actually a pretty high-risk thing. And it's kind of funny, I chose this study before ChatGPT blew up and everything, and so I think now it's even more prescient than when this study came out. And this was a study in France where they basically, this one company is developing an AI algorithm to help with radiograph interpretation. And so they basically just compared how are the radiologists and the ER docs at reading radiographs without the use of AI, and then compared with the use of AI, and then they studied that. So this is what it actually looks like in practice. I think this is super cool. So you get an X-ray, and then the AI basically puts these boxes on the areas where the AI thinks like, oh, something looks abnormal. And then based on the AI, it tells you with certainty, okay, this is definitely a fracture. We think it's 99% fracture. In this site, we see something abnormal here, and we're gonna say it's doubt fracture, but our confidence is only 50%. Same thing down here. They doubt it's a fracture, but confidence is 69%. So that's how the AI can kind of go through, and it can highlight things that you might miss on your initial interpretation. And what they found was that the AI improved the sensitivity of the physicians in detecting fractures, going from 70% to 79%, and specificity also increased by about 4%. And it reduced the number of false positive fractures by about 41%, and it decreased the reading time. So this was a very small study with a relatively new AI. But I think the question is, what are we going to do with AI? With the explosion of ChatGPT, even just within the last couple of months, I think we need to consider seriously how we're going to implement it. I don't think as physicians we're going to be replaced by AI. There's always going to be a role for us, but I think it's going to be a question of how do we use it. Specifically with the AI radiograph interpretation, how many hospitals don't have a radiologist reading plain films overnight? I certainly think a lot of smaller community hospitals have that. I've worked at a shop that didn't have that, where the ER doc had to interpret their own radiographs. So what if you had this as a tool to help you with that? I think it's something that we're going to have to learn to use and benefit our clinical practice. And then this final study of the day was direct access PT to help patients with MSK problems in the emergency department. I'll be honest, the secret to sports medicine, like primary care sports medicine, is I send patients to PT. That's really all that I do in clinic. Sometimes I get to inject them with steroids, and those are the fun things, PRP, things like that. But ultimately, if all my patients just went to PT, got themselves stronger, got themselves moving, the vast majority of the time, patients would be doing better. And so I think this is a really unique idea to have PT access in the emergency department for minor MSK complaints. I think a lot of us probably work at shops where we're able to get PT down to help evaluate a patient to determine if they need to be admitted for placement to rehab or a SNF in the older patients. But they use PTs here for just all MSK complaints. So think of ankle sprains, falling on an outstretched arm, rotator cuff tears, minor things like that. It was just a single center in Quebec, and they basically, after the nurse triage identified the minor MSK complaint, they had the physical therapist evaluate the patient, do a full session with them, and then the ER doc came from behind and then just added on anything else that they wanted to do with medication or whatnot. And basically they found that those that were randomized to receiving the PT intervention had decreased levels of pain and disability at 1 and 3 months. They noted that they returned to the ED less often than the other group, and that there was less prescription pain medication used in the PT group. And so my takeaway, PTs are experts in musculoskeletal pain. I'm supposed to be an expert in sports medicine, and I primarily just refer them to them. And so I think it's something that if we could implement this on a wider scale for a lot of our MSK patients, it would have a lot of benefits further down the road. So that's all I got. We went through my top articles in 2021, but my big takeaways: low back pain is difficult to treat. Nothing works better than time, no matter what we throw at them. The serratus anterior block is easy to learn and effective for rib fractures. consider magnesium oxide for concussions. It's got very little downside, may be beneficial. You don't need an X-ray in classic Nursemaids. And AI may completely change EM. How are we going to use it? And consider in-house PT. There are always room for innovations. So, thank you. Questions? Yes? 500 milligrams magnesium oxide. Yeah, that's really just like the cheapest, most common form. If you go to the supplement aisle, there's tons of different variations of magnesium. I don't know that it really matters, but I think the study design and what I typically recommend is just 500 of magnesium oxide. Yes, at night primarily. Yep, just a one-time dose. Yes.
All the studies for back pain that you looked at were acute back pain?
Yes. Yes.
Has there been anything in terms of like chronic back pain or IC?
Yes, so essentially the same thing. For chronic low back pain, NSAIDs don't do much, muscle relaxers don't do much. Even PT, honestly, doesn't do much. And I'm a huge advocate for PT and low back pain, but the studies, when they actually look at it, really doesn't make a difference. The studies that have looked primarily at chronic low back pain, the biggest thing is actually movement. There was a study looking, basically just any form of exercise had the biggest effect on pain and disability. And then after that, it was some of the interventions, like NSAIDs was number 3 or 4 with most efficacious. But really, that's what I try to counsel my patients, that generally things get better with time and with movement. And a lot of patients hate to hear that. They're like, "Doc, you're telling me to move. I can barely move my back right now." And you just have to coach them through that. It's like we're talking gentle range of motion, getting some movement in, and over time they'll feel better and can progress from there. Yes?
What do you think of the erector spinae plane block for low back pain?
There is some interesting studies like the plenary session that we just had. I think it's great. I mean, I think any tool that we have is going to be useful. The erector spinae block has more of a theoretical basis of you're actually blocking the nerves coming from there. Again, I don't know if that's necessarily more effective than trigger point injections or the intradermal saline. We don't have a study to support that. It is certainly more invasive and potentially more dangerous since it's a deeper injection, but potentially more efficacious. So I'm really excited. Hope someone somewhere does more studies to help prove that. That may be featured in a future talk once it gets published. So, yeah, in 2025, exactly. Anything else? All right, thank you, everyone.